is Zoher Ghogawala. I'm the chair of neurosurgery at Leahy Clinic and associate professor of neurosurgery at Tufts University School of Medicine.
My name is Srinivas Prasad. I'm associate professor of neurosurgery at Thomas Jefferson University in Philadelphia. I do almost exclusively spine surgery. Today we're going to talk about decision making with respect to cervical myelopathy. So ways of addressing patients that come in and some of the ways that you select the right procedure for the specific patient in question. So Zoe, I know you've written a lot about this and certainly are conducting a lot of research on it. One of the considerations that I think maybe the easiest one to lay out is how many levels are involved in terms of deciding. So in my book, and I know there's some variability in this as well, I think number of levels is a general rule. 1 or 2 levels I like doing from the front, like an anterior cervical discectomy. 3 or more, but more than 3 levels for sure I do from the back. But 3 levels is always where there's this position of equipoise, this thing that you coined, this term of clinical equipoise in myelopathy. And that's I think maybe one of the primary drivers when I'm teaching fellows and residents. I say how many levels need to be decompressed, and that tends to start it off. What are other things you think about?
So I think that's a really good point. 1 or 2 levels, most of us go from the front, as you say. 3 more levels gets more complicated. I think of things like whether there's OPLL or not. Even if there's 2 levels and there's OPLL, I'll probably go from the back. And the other thing I think is very relevant is what's the overall alignment of the spine. There's certainly good data to suggest that patients who are kyphotic are probably better treated from the front than from the back. Sometimes you can change that overall orientation, but I think OPLL, overall orientation, degree of kyphosis of the spine are important considerations. Like you, I think we recognize that there's a certain amount of literature and data on this, but you look at a case and you and I might just see it totally differently, and it's probably because at that moment in time, a particular feature of the case is drawing your eye more than another aspect of it. What are some of the other things you think about?
Yeah, I mean, we're almost leading into it. I think location of pathology is probably an important thing as well. If there's a very large disc herniation associated with it, I might favor the idea of doing it from the front. Certainly there are concerns about arthrodesis. If that's a concern, a smoker, I would still offer surgery where, like for low back pain or something else, I might not. But in a smoker, I think myelopathy still warrants surgery, and I might change either to the type of graft material I use or bone marrow aspirate or doing a front back in those situations. But certainly location of pathology is a primary driver. And OPLL or big calcified discs pose a real challenge sometimes in that scenario. I think what levels matters as well. I think, so if I'm crossing the cervical-thoracic junction, it's inaccessible, and maybe somebody who's overweight, I think that's a real challenge. And sometimes you're kind of boxed into only doing one or the other. The other thing I would say is in establishing the goals, we said how many levels involved. If radiculopathy is a real component and there's ventral pathology like oncovertebral hypertrophy or something where I feel like I may not be able to do a good foraminal decompression, that might push me towards doing the front as well. I think those are kind of the primary things I would say. Are there other things that you think are important?
One of the things that I think is always good to talk about is laminoplasty.
Yeah.
Laminoplasty has had relatively less penetration in the United States compared with the rest of the world. But we're seeing more and more laminoplasty in our practice, and I think certainly from my practice as well. I have always thought of patients with congenital canal narrowing as good candidates for laminoplasty, people who are younger, who want to preserve motion as good candidates for laminoplasty. But what are your thoughts in terms of when do you apply laminoplasty in your practice?
Yeah, I think it's morphed a little bit over time. I still think you have to have some degree of lordosis. I know there are those that say you'll tolerate 4 or 6 degrees of kyphosis even and still consider doing it. But I get flex x-rays on all of my patients, to make these determinations about alignment. I get CAT scans as well in all my patients. But they have to be lordotic. And generally the teaching was painless cervical myelopathy with preservation of lordosis. But I think there's literature to suggest that maybe the painless part is more controversial, that fusions can actually render more pain, and that we should think about laminoplasty even when people have some degree of neck pain. So I think really, as you said, congenital stenosis with lordosis, I think it's something to really think about.
Pain, I think, is a really important issue. As you say, a lot of the advantage of going from the front is the reduction of pain. People get out of patients get out of the hospital sooner. They feel better. There are problems with dysphagia that we should probably talk about. But pain from posterior surgery is an issue. One of the things that we've learned in the literature is that Patients who have a positive sagittal alignment or positive sagittal axis, C2 to C7 greater than 4 centimeters, those patients have more neck pain. Those patients have more neck pain posteriorly primarily, but also anteriorly. One of the things that I think we find is that some of the people that we treat with laminoplasty actually correct their overall alignment over time. And that's sort of an interesting phenomenon. But at least in my practice, I tend to see less neck pain with laminoplasty if, as you say, and you mentioned, with flexion extension, they're not moving pathologically at one level or two levels.
Do you have any thoughts? So that's great. I agree with that. I think laminoplasty is powerful. What about crossing the cervical-thoracic junction? Like, how do you address it? When do you stop at 7? When do you go to 1 or 2?
Yeah, good question. If I can stop my construct with instrumentation at C6, then I'll do a dome laminotomy at C7, and I will stop there. If, though, I feel that decompression needs to be done that includes C7 or needs to cross over to T1, then I instrument down to T2. And in those cases, I'll always do an instrumented fixation. That's kind of my general approach. How about yourself?
Yeah, no, I think over time I've gotten to do more of that, stopping at 6, because 7 you have problems with instrumenting it, pedicle screw, lateral mass screws, those could be real challenges. The only other thing I would add, I think we kind of covered all the major determinants of whether you go anterior, posterior, laminoplasty. The only thing I'd ask is I've become better about asking people, counseling them about phonation problems, voice changes, swallowing problems, and asking them. And I've been surprised a number of occasions where people say, actually, swallowing's a problem for me. Like if you're, or I'm an opera singer, or I'm a bar singer, and it's a really big deal for me to be able to sing. In which case, I think as long as we counsel patients about it, that can influence the approach as well. But I think we kind of covered most of them. One thing, if you don't mind commenting on, especially since you're doing such an important, you're running a very important trial right now, randomizing patients in so-called clinical equipoise to anterior and posterior approach. Can you tell us a little bit about that study?
Sure. This is a study that is 15 sites. It's federally supported by PCORI, and the NIH organized the initial study group. But what we do in this study is we look at all patients with cervical myelopathy, with multi-level cervical myelopathy, and you, I, orthopedic surgeons, neurosurgeons, we vote on these cases. And we see if there's a predominant preference for an anterior or a posterior approach, then that's what we recommend to our patients. But as you say, there is real equipoise in over half of the cases that we see that are multi-level. And if there's real equipoise, then we talk to the patients and then we randomize them to ventral versus dorsal. If they're randomized to dorsal, they either get a laminoplasty or a decompression and fusion. And right now, with 15 sites, we've nearly completed enrollment in this randomized study, and we should have data within the next couple of years.
That's great. Thanks. Hopefully it'll give us an answer for the best way to treat this.
Hope so.
Good afternoon. This is Todd Albert, and I'm sorry I can't be with you today. I'm in New York City taping this because I've recently had surgery and I'm not being allowed to travel from after my hip scope. I'm on crutches but recovering well. I'm going to give you a 1 to 2 minute thought on how I approach myelopathy, anterior versus posterior, and I'm sure you'll hear some more erudite comments from Zoher Ghogawala and Srinivas Prasad. But when I see a patient with myelopathy, my first goal is to understand how severe their myelopathy is. Is it just cord compression without myelopathic findings, or are they truly myelopathic? And if they're truly myelopathic with cord compression, when I want to talk about the best approach for their surgical treatment, for me it's dependent on the number of levels. Do they have OPLL or not? If they have OPLL or not and it's retrovertebral, I'm often going to try to go posteriorly. But critical to that decision is what their sagittal alignment looks like. Are they neutral or lordotic, or can they become lordotic in extension? If they're multi-level, if they're greater than 3 levels or more, and they're lordotic and do not have significant neck pain, I love the approach of laminoplasty for that patient. If there's any instability, or they need a significant amount of extension to become lordotic, and they have neck pain, I will lean toward a laminectomy and fusion. If it is limited levels and it's retrodiscal compression, I love an anterior cervical decompression and fusion for those patients for spondylotic myelopathy. And or if they're kyphotic and need to be made lordotic, I think patients can be really effectively made lordotic with intersegmental correction, with converged Caspar pins that we open and get a few degrees correction at each intradiscal level. We can really help with their alignment. And in general, for my patients, tolerate an anterior cerebral decompression infusion better than a posterior operation, less pain, only some minor swallowing dysfunction, and you only have to worry about the fusion becoming solid, which is not insignificant, but the more levels we do, but less of a problem today than in years past. That's just some beginning thoughts, and I'm sure the guys in the room will comment on it. I'll be available by cell phone if they want to ask me a question about what I've said. But again, I'm sorry I can't be there with you, and I hope the discussion is terrific. Thank you.